quick recap of what the normal colonic mucosa looks like. Okay, here there are a few things I want you to pay attention to. One is that the surface is smooth. It is not villiform as the small intestine. The second thing is, below the mucosa, is the muscularis mucosae, then the submucosa and the muscle propria, as you all know. And the pattern of arrangement of the crypts or the glands in the mucosa is very uniform. That is, it is almost like a rack of test tubes, it is called. So these are all the glands are parallel to each other, and the long axis of the gland is perpendicular to the surface. Okay, so this is the normal mucosal pattern, and this is the normal histology of the colonic mucosa. Why is it important to know that? Because only if you know the normal can you pick up the abnormal, right? So now let's look at the normal mucosa again, but in slightly different parts of the intestine. So this is the way it may look like in the transverse colon. This is the way it will look like a slightly higher part in the ascending and transverse colon mucosa, where again there's an occasional crypt which is branched like this, but otherwise most of the crypts are just single. They are long, arranged as test tubes in a rack, and with the long axis, like I said, that is perpendicular to the surface of the mucosa. So this is the normal arrangement with some inflammatory cells, which is a normal gut-associated lymphoid tissue that is present in the mucosa in the lamina propria. Okay, but you don't have too much inflammation in the submucosa. In the rectum, especially in the lower part of the rectum, you can see a little bit of sparsity of glands compared to the other parts of the mucosa. And however, you will still see that orientation, that is the long axis being parallel to each other, still remains, even though some of the glands appear to be slightly more sparse. And this is the anorectal junction, where the squamocolumnar junction is present at the anorectal squamocolumnar junctional. And here sometimes again there may be a slight loss of that normal parallel orientation, but by and large it remains in a very short, small area at the anorectal junction. And so this area is seldom biopsied when we are talking about inflammatory bowel disease. So, inflammatory bowel disease, two main components, ulcerative colitis and Crohn's disease. Now, it is important to be able to differentiate them, and that is something that I told you I'll take up as the third part of this lecture. However, as we go along describing these, I will still continue to tell you the differences, which we will then sum up at the end of the lecture. Okay, so ulcerative colitis is a mucosal ulceration. So only the mucosa is involved, whereas Crohn's disease is the transmural inflammation. That is, the inflammation extends from the mucosa to the submucosa, muscle, and all the layers of the wall of the colon are involved. Now, whereas here mainly the large intestine is involved, here it could be an ileitis, that is a small portion of the ileum, it could be an ileocolitis or just a colitis. Since different regions can be involved in isolation, it is also called regional enteritis. So this is the way ulcerative colitis will be present, and ulcerative colitis is typically described as a distal disease. That is, the disease is most severe in the distal part of the large intestine, so in the rectum. So it may involve just the rectum and sigmoid, or it may involve the left side of the colon, or it may extend towards the right side. Any part of the colon can be involved, but it is involved in contiguity, continuous involvement of the colon, with most severe inflammation in the distal part. There are no patchy areas of lack of involvement, that is normal mucosa, in ulcerative colitis. Whatever the extent of disease may be, whether it's only involving a small part of the large intestine or going right up to the cecum, but it is a continuous involvement with no patches of normal mucosa, and the more severe inflammation is usually always in the more distal regions. Then here, the what you will see is, look at the red portion. The red portion is the diseased portion. The pink and the maroonish portion are healthy. So this is the submucosa, this is the mucosa, and this is the muscle. So the mucosa, which is red, this is the involved area. That is, the inflammation is mainly in the mucosa. It is not in the submucosa or muscle. Now, unlike this, let's look at Crohn's disease. In Crohn's disease, you look at where these white arrows are pointing and these little red circles, if you can see. So in Crohn's disease, you will have patchy involvement. You can have just the ileocecal region, just the transverse colon, or both of these involved with normal mucosa in between. Just the ileal segments can be involved, but there will be normal mucosa in between, which is not involved by the disease. But on the other hand, the mucosa is not the only part of the wall that is involved, but the entire wall, submucosa, and even the muscle wall can be involved in Crohn's disease. So it is a transmural inflammation. This again is highlighting the same thing. Ulcerative colitis, a continuous involvement of various parts of the intestine, whereas Crohn's disease, patchy involvement of various parts of the intestine with intervening normal mucosa, and sometimes only the rectum can be involved, similar to ulcerative colitis, but usually here then there are fistulas and fissures that are present in the rectum, unlike in ulcerative colitis. So what is the epidemiology? Females more than males. Usually starts in adolescents and young adults, but it can occur in older adults as well. Now we are seeing an increasing incidence of both ulcerative colitis and Crohn's disease, and especially of Crohn's disease. But there is an increasing incidence world over, including in India. In India, ulcerative colitis is much more common than Crohn's disease, but gradually we are seeing more cases of Crohn's also. One of the reasons for this is the hygiene hypothesis, wherein they feel that it is because of the presence of improved hygiene that the normal gut flora is altered, and this leads to more of immune-mediated mechanisms. The hygiene hypothesis is a popular hypothesis for many immune-mediated disorders, including ulcerative colitis and Crohn's disease or inflammatory bowel disease. So let's have a look at the etiopathogenesis. Now, before we look at the etiopathogenesis, one little quote which came out in the Digestive Disease Week. Time and again, we learn that treating the cause of a disease always beats treating the symptoms. So that is why understanding the pathophysiology of a disease is very important. You cannot just give symptomatic treatment. That will only give temporary relief to a patient. Unless you understand the cause of the pathophysiology, only then will you be able to root out the disease or treat it at its root. So pathophysiology matters and puts the patient first. So looking at the pathophysiology of IBD, it is multifactorial. So there are host or genetic factors. There is intestinal microbiota, gut microbiome, mucosal immune response, epithelial dysfunction, and it is an interplay of all these factors that ultimately result in inflammatory bowel disease. Now, in addition to all that, there are certain environmental triggers. For example, excessive antibiotic use, certain dietary substances, smoking, stress, anti-inflammatories, non-steroidal anti-inflammatory drugs, and certain infections can trigger inflammatory bowel disease in a susceptible individual. So now let's look at each of these factors that we know are involved in the pathophysiology of inflammatory bowel disease. First is the host factor, which is genetics. Now there is increased susceptibility, it has been found in families and especially in monozygotic twins. This is especially true for Crohn's disease more than ulcerative colitis. So the fact that this is increased susceptibility in families and twins points towards a genetic association. Now, it has been found that a particular region that is called NOD2, which is the nucleotide oligomerization binding domain 2, this particular region is especially associated with the presence of Crohn's disease especially more than ulcerative colitis, and it has been found that mutations in this region are make the person more susceptible to the effects of both epithelial dysfunction and the intestinal microbiota. So, as I said, it's multifactorial. So, the presence of NOD2 mutations can make the individual more susceptible to Crohn's disease. However, again, I will highlight the fact that it is only more susceptible. So it is a multifactorial involvement. This NOD2 region lies in chromosome 16. It affects the innate immunity through the NF-kappa beta mechanism, and recognition of microbes is affected. So how the microbes are affected and presented, and therefore the innate and humoral and the T-cell mediated immunity, and it also affects the apoptosis of the cells that are the macrophages that are having these microbes. So if it affects the apoptosis, there is no apoptosis, then these microbes that are present in the macrophages, the antigen presentation occurs, and then the immune mechanisms take over. So that is something that I'll show you in the subsequent slides. However, again, like I said, it is only an association, and it is a multifactorial system that is involved, because only less than 10% of those with NOD2 mutations or polymorphisms actually have disease, whereas 90% don't. However, a strong association has been found through genome-wide association studies for NOD2 polymorphism and Crohn's disease. There are other two autophagy-related areas in our genome, that is the autophagosome pathway, that is the autophagy related 16-like-1, ATG 16-like-1 region. Mutations in this region again are associated with Crohn's disease and ulcerative colitis, but more commonly Crohn's disease. Why? Because autophagosomy occurs, again, the phagosomes that are holding the bacteria, the intracellular bacteria, if they do not undergo autophagy, then these autophagosomes, because of the presence of these mutations, autophagy does not occur, and it stimulates again the immune response. Similarly, immunity-related GTPase M. This again has a role in autophagy and clearance of the intracellular bacteria. Again, if this does not occur, the antigens of the bacteria are presented to our T cells, and then it is related to the immune mechanism. All these mechanisms are somehow more commonly found for Crohn's disease than for ulcerative colitis. The second area that is important is the mucosal immune response. So, here I'll just show you there is an interplay of interleukins, T helper cells, and various other factors such as tumor necrosis factor that allows the entry of the microbes and generation of the immune response that gives rise to the ultimate histological features of inflammatory bowel disease. And this is further proven or supported by the fact that immunosuppressive and immunomodulatory agents remain the mainstay of therapy for inflammatory bowel disease, because this mucosal immune response is one of the important etiological mechanisms. So here is a diagram which I think is given in your Robbins textbook, which very nicely summarizes all these factors. I've just added a few things to it. So these bacteria, and we'll come to these, the bacteria that are present on the surface of the mucosa, some are adherent, and these bacteria then, when they enter the epithelial barrier, they go through the epithelial barrier, they're taken up by the dendritic cells. Now, if autophagy does not occur, then the antigen presenting cells present these antigens to the T cells. And the T cells will further then either stimulate the T helper cells, which then give rise to tumor necrosis factor, secretion by the macrophages, tumor necrosis factor will further cause injury to the epithelium and therefore lead to an increase in the barrier defect, which will further cause increase of entry of the bacterial components into the mucosa. Furthermore, these dendritic cells can produce interleukin 23, which is a very important stimulant of T helper cell 17, again producing interleukin 17. Now, this will cause migration of the neutrophils to the area, which again then will cause injury and is part of the histological features that we see the presence of neutrophils in active ulcerative colitis. The T cells will also stimulate T helper cell 2. T helper cell 2 is especially mediated, part of the mediated response for ulcerative colitis. Both interleukin 10 and 13 are produced, and they in turn cause production of tumor necrosis factor and further injury to the epithelial components. So there may be further polymorphisms in the extracellular matrix domain 1, which lead to defects in the intraepithelial tight junctions. So if these intraepithelial tight junctions are defective, again the bacterial components can enter the mucosa easier. So it is an interplay of all these factors that is part of the pathophysiology of inflammatory bowel diseases. Coming again to the epithelial defects, these defects are in the epithelial tight junctions and have again been found more in Crohn's disease, both in the patient and in the healthy first degree relatives. Now, these intraepithelial tight junction defects can be associated with the NOT2 polymorphisms, and these barrier dysfunctions can activate the innate and adaptive mucosal immunity, as you have just seen in the previous diagram, right? Now, what is the role of the microbiota? The intestinal microbiota can contribute to IBD pathogenesis. How? Now, the colonic mucosa has actually 2 layers of mucin. An outer luminal layer, which is more loosely adherent, and an inner tightly adherent thicker mucus layer, which is adherent to the epithelium. Now, these layers also have the normal healthy microbiota. And it has been seen that in ulcerative colitis, this inner mucus, tight mucus layer may have an increase in E. coli and a decrease in the healthy microbiota. And this can be one of the reasons for the presence of inflammatory bowel disease. As you have seen in the previous diagram, these bacterial antigens can then trigger the immune response. And it has been found that certain antibiotics and metronidazole can be helpful in maintenance of remission. They do not cure the disease, or they are not very useful in decreasing the disease. For immunomodulators are the mainstay of treatment. However, they can be helpful in maintaining remission in Crohn's disease. And similarly, the role of probiotics is coming up, and even of fecal transplants. Now, probiotics increase the normal gut flora, and fecal transplant from healthy individuals of the normal gut flora into the colon of an unhealthy individual with IBD, again, are both based on the fact that the intestinal normal microbiota is changed, replaced by the unhealthy increased E. coli, and that causes triggering of the immune response. So if we can increase the normal microbiota by probiotics or fecal transplants, that may help in removing the pathogenic E. coli and decreasing the immune response to it. Now coming to the histology. So the histological features of IBD are basically, it is an acute on chronic colitis. Sorry, the photograph seems to have gone, that was present over here. It's not showing up. Anyway, so it is an acute on chronic colitis, and this acute on chronic colitis, I'll show you the differences in the subsequent slides. One of the main hallmarks of this acute on chronic colitis is the presence of plasma cells in sheets in the basal region. Now, what do we mean by the basal region? The basal region means at the bottom of the crypts, between the base of the crypts and the muscularis mucosa. Now, normally in the colon, you see a uniform distribution of lymphoplasmacytic cells like I showed you in the initial slides. And in an infectious process, in fact, you see more of these increase in lymphoplasmacytic cells at the surface. However, in ulcerative colitis or inflammatory bowel disease, you will see more of these lymphoplasmacytic cells at the base of the crypts, between the base and the muscularis mucosa, and that is called basal lymphoplasmacytosis, which is an excellent marker of IBD. Now, somehow this seems to be shifting and the photograph is not there. I hope the subsequent photographs are there. Now, let's look at some cases. This is a 28-year-old male with 6 weeks history of loose motions with blood in stools. This is the typical presentation of ulcerative colitis. And abdominal cramps, which ease after passing stools, and urgency to move the bowel. Now, here is a colonoscopy with diffuse continuous involvement of the rectum, sigmoid and colon up to the splenic flexure. Now this, some of these photographs all seem to be missing. I don't understand why the photographs are missing. They are not showing up on your webinar. In which case, that will be a very dull presentation with no photographs. Yes, none of the photographs are showing. So maybe I'll just stop presentation and I will just reload the presentation and see if that helps. Presentation is not showing these slides somehow. Let me open the other one. Okay, hopefully this one will show it. Okay, can you again, some of the audience, just tell me if the screen is shared right now? Can you just tell me if the screen is shared and you can see it? Okay, so I think you can see the screen. So now, so this is, I just told you that the basal plasmacytosis is an important feature. And basically, it is an acute versus chronic colitis. Okay, so since it is an acute versus chronic, acute on chronic colitis, sorry, not an acute versus chronic colitis. IBD is an acute on chronic colitis. Okay, so there are features of chronic colitis and there are features of acute colitis. When the patient is in remission, you may see only features of chronic colitis. When the patient has active disease, you will see features of both acute and chronic colitis. So it is important to know these features individually. So when the crypt architecture is disturbed, then it is chronic colitis. There is expansion of lamina propria in both acute and chronic colitis. However, lymphoplasmacytic cells more in when it is just chronic, and when there is an active colitis, neutrophils and some eosinophils are present. Basal lymphoid aggregates, that is lymphoid aggregates and lymphoplasmacytosis at the base of this mucosa, that is what you see in a chronic colitis, but not usually in an acute colitis. Granulomas may be seen in chronic colitis, Crohn's disease, not in ulcerative colitis. cryptitis and crypt abscesses. I'll just tell you exactly what these are in the subsequent slides. These are, as you can make out, an abscess and itis usually mean inflammation. So this is neutrophils in those crypts, in those mucosal glands or crypts. These are present in both acute and chronic colitis, but they are less often present in chronic colitis. So when the patient is in remission, they may not be present. They will be present when the patient is in active acute or chronic colitis. Pyloric or Paneth cell metaplasia. Again, I'll show you an example later. So this is not present in an acute colitis, but will be present only in a chronic colitis. And fibrosis may be present in a chronic colitis. But IBD is an acute on chronic colitis. So you will see an admixture of these features in IBD. So this is again that basal lymphoplasma cytosis that I was telling you about. These are the crypts. This is the muscularis mucosae. Okay, so now normally the crypts extend right up to the muscularis mucosae, which is what you saw in the initial slides that I showed you. But what happens in this chronic colitis that there is shortening of these crypts, and instead in this area between the crypts and the muscularis mucosa, you see the presence of lymphoplasmacytic cells. So this case I was telling you about, so this is the normal colon in which you see this vascular pattern. You see this web-like pattern of superficial vessels which can be seen on endoscopy, and there is a loss of this vascular pattern along with some ulcerations in IBD. This is what you see in IBD, and this is what was seen in this patient. Then what did we find in biopsies from this patient? That there was loss of normal crypt architecture. As you can see, there is even loss of crypts, paucity of crypts, distortion of architecture, some branching and budding glands. The long axis is all haphazardly appeared, and there is this basal lymphoid aggregates and basal plasmacytosis that we are seeing. Okay. Then there are features of acute colitis or activity also in this patient. How? We are seeing neutrophils and eosinophils, these bright orange colored neutrophils and eosinophils, not only in the ramina propria, but they are also collected in the lumen of the crypt and infiltrating the epithelium of the crypt. So that is cryptitis and crypt abscesses. This is a feature of activity. So what is the diagnosis in this? This was a uniform continuous involvement on endoscopy that they told us. And so we see these features histologically, and the diagnosis is ulcerative colitis, right? So next, what is the gross examination? Now usually the patients are treated with so there are certain medications that decrease the inflammation, and then immunomodulatory and immunosuppressive therapy. However, if the patient does not respond to treatment, then sometimes surgery is the only option. And then if the patient undergoes surgery and the specimen comes to the pathology department, what do we see? We see that it is a distal disease. So usually either the rectum is involved, or the rectum and left-sided colon is involved, or it may be a pancolitis. That is, the entire colon is involved. And if there is a pancolitis, sometimes up to 5 centimeters, 2 to 5 centimeters of the ileum from the ileocecal junction going backwards up to 2 to 5 centimeters may be involved of the ileum, and that is called backwash ileitis. And it should not be confused with the involvement of ileum in Crohn's disease, wherein the ileum beyond this 5 centimeters is involved, and only ileum can be involved with a sparing of the ileocecal region. That is in Crohn's disease. But here in ulcerative colitis, there may be a backwash ileitis. There are areas of ulceration, and there are areas where the mucosa is inflamed and edematous, and therefore looking like it is rising above like a polyp beyond the ulcerated mucosa, and therefore these are called pseudopolyps. So this entire region is involved, and now here again the mucosa is healthy. So it is involvement of the distal mucosa, and then proximal to that there is healthy mucosa, and this is the typical feature of gross features of ulcerative colitis. Inflammation is lymphoplasmacytic, like I said. It can be dense, homogeneous. It expands and thickens the lamina propria. There is basal plasmacytosis, but as you can see, most of the inflammation is limited to the mucosa. and maybe the superficial part of the submucosa, but most of the submucosa and the muscle propria, these are uninvolved in ulcerative colitis, unlike Crohn's disease. So here you can see the dense inflammation and lymphoid aggregate formation. Lymphoid aggregates almost with follicles with germinal centers, these are formed. And sometimes when it's a very severe disease, the muscularis mucosae may also get involved, and it can spill into the muscularis submucosa, but usually there is not a transmural inflammation. Here again, you can see the lymphoid aggregates and dense homogeneous involvement. And here you see the presence of activity again, neutrophils forming cryptapsises, so a very active acute on chronic disease, which is the hallmark of inflammatory bowel disease. This is a pseudopolyp where this is the mucosa, and then here this is a polypoidal elevation of the same type of mucosa, but with the inflammatory cells and edema have pushed this mucosa up to form a polypoidal projection. Therefore, it is called a pseudopolyp because it is not a polyp due to proliferation of the glandular epithelium, but a polyp which is just due to the edema and inflammation pushing up the mucosa, and therefore it is called a pseudopolyp, and it's not a true polyp, which you'll see in the next class. Then other features of chronicity are these little branching, budding appearance, completely haphazard arrangement instead of those rack of test tubes, and you can get some Paneth cell metaplasia. Paneth cells are these orange granules in the mucosal epithelium. Normally, the large intestine has predominantly these mucus-filled goblet cells, and Paneth cells can be seen in the cecum only, or a little bit in the ascending colon, but not in the remaining part of the large intestine. They are seen in the small intestine. But if you start seeing Paneth cells in the transverse colon, sigmoid, and rectum, then that means this is Paneth cell metaplasia occurring in a case of inflammatory bowel disease. They can also have several extra-intestinal manifestations, such as migratory polyarthritis, sacroiliitis, ankylosing spondylitis, uveitis, primary sclerosing cholangitis, etc. These are all immune-mediated mechanisms leading to these extra-intestinal manifestations. Now, if you can quickly type into your screen, what is the area marked by the blue arrow and what is the area marked by the red arrow? So if you can quickly type the answer, then we can see if you can recognize these areas that are typed in by the blue and the red arrows. I'll give you a short minute. So the red arrow is, can someone tell me what the red arrow is? What is the red arrow showing and what is the blue arrow showing? Yes, so the red is ulceration and the blue is pseudopolyp. Very nice. Vishwa, Rakesh and Shashwat. Thank you. At least I know somebody is listening to the lecture. So this is a gross photograph of a case in our department wherein this red arrow shows all the ulceration and the blue arrow shows the pseudopolyps. Now, 2 years later, what happens to this patient? The patient developed fever, severe abdominal pain and abdominal distension. So this is, let's go back to that first case where I showed you the colonoscopy and the biopsy, right? So I showed you the colonoscopy and the biopsy. In between the resection specimen I've showed you is a different case, just to complete the picture. Now that first case where you saw the biopsy, 2 years later after treatment also the patient develops fever, severe abdominal pain and distension. And here the likely diagnosis is toxic megacolon. Sometimes they do not respond to therapy and they, because of the proliferation of the various microbiota in the intestine, they develop what is called a toxic megacolon, which is an acute abdominal emergency, and the patient needs to be operated. The colon is markedly distended, clinical radiological diagnosis is made, and the patient needs to be operated. Now, let us say that this case did not develop a toxic megacolon, did not get operated. Let us say this case was on follow-up, treatment, intermittent remissions and intermittent activity, and 12 years later the patient develops loss of weight 8 kilograms in 6 months, mild recurrent abdominal pain, loss of appetite. So there are two very important features there, loss of weight and loss of appetite. What is the likely diagnosis? A colonoscopy is done, and what we see along with the ulceration are these mass-like lesions. Despite the fact that here the vascular pattern is maintained, here we are seeing these two mass-like lesions which are much larger than pseudopolyps. Okay? And on a biopsy is taken of such a region, what we see are these irregular glands that are infiltrating the muscularis mucosa. These are some fibers of the muscularis mucosa, and these irregular atypical glands with hyperchromatic nuclei and a lot of nuclear stratification and crowding that are infiltrating, and this is an adenocarcinoma. So the diagnosis here becomes adenocarcinoma, which is another complication, a very important complication for which the patients must be followed up. So the patients must remain on a regular follow-up, and especially after about 8 to 10 years, adenocarcinoma becomes a serious condition that they can come with, and therefore regular follow-up is essential. Now let's look at a different case, a 38-year-old female with diarrhea, weight loss and abdominal pain, and pain in the perianal region, and in addition she had oral aphthous ulcers. Now here rectosigmoidoscopy was done, and near the rectal region long fissuring ulcers were noted, deep and long fissuring ulcers. And here, the colonoscopic biopsy which was taken shows the presence of acute and chronic inflammation in the ramina propria. And in addition, what we are seeing are this small collection of epithelioid cells. You just heard a lecture on tuberculosis last week. So there's a small collection of epithelioid cells. There's no giant cell. There's no caseous necrosis. So this is a case in which a diagnosis of Crohn's disease must be considered. So Crohn's colitis, wherein the patient presents with anal fistula or anal fissures, there can be intermittent involvement of other parts of the colon. Now, if such a patient is operated, what you see grossly in the specimen is that it could be right-sided colon or ileal involvement. So whatever area is involved, that is the area that is usually operated and sent. What you see again are the presence of these fissuring ulcers and cobblestones. That is, like pseudopolyps, what you may get is just edematous areas instead of pseudopolyps, though you can get pseudopolyps, and those are areas that give a cobblestone appearance. But one of the very important features is the presence of strictures and creeping fat. Strictures are not common in ulcerative colitis, they are more common in Crohn's colitis, and creeping fat. Now the fat that is present, this fat in the normal colon, is usually the mesocolon and a little bit around that area. But when you see that almost complete transversely the fat has started creeping around the entire width, diameter of the colon on the external surface, then that is something that should allow you to think of Crohn's colitis. This is the typical cobblestone appearance of Crohn's colitis. Here you can see a small area that is uninvolved, and again patchy involvement, again some normal uninvolved areas and some involved areas. Here again some involvement is there. So a patchy involvement of the colon with fissuring ulcers, cobblestone appearance, and creeping fat around the entire colon, maybe a few strictures, should make you think of Crohn's colitis. And here what you can see is the presence of a deep fissuring ulcer. So this is the mucosa, muscularis mucosa, and the inflammation is extending right down through the submucosa and into the muscle propria, which you can see here. So these deep fissuring ulcers are typical of Crohn's colitis. Architectural disturbances may be patchy. Paneth cell metaplasia is more common in ulcerative colitis, but what you commonly get here is a gastric type of mucosa, pyloric metaplasia. That is more common, but you can get Paneth cell metaplasia also. And then another very important feature is the presence of lymphoid aggregates along the outer border of the muscularis propria. Now, if any of you are familiar with rosary beads, which people use when they are praying, now this gets its name from that. It's called Crony Rosary. because you see these round lymphoid aggregates that are present throughout the colonic mucosa beyond the muscularis mucosa, and these lymphoid aggregates give the appearance of a beaded appearance, and this is called Crony Rosary, and can even be seen in the areas that are not showing any active or acute inflammation. So even the areas that are relatively normal in appearance, the patchy areas, normal areas, those can also show the Crony Rosary. 3 years later, she presents with severe abdominal pain and distension. The likely diagnosis is stricture formation here. Why? Because there is a stricture, therefore there is distension of the proximal mucosa causing abdominal pain. Again, an acute abdominal emergency which may need surgery. 7 years later, the patient presents with passing fecal matter per vaginum. Likely diagnosis, rectovaginal fistula formation, another important complication of Crohn's colitis. So these are some of the important complications of Crohn's colitis. Of course, iron deficiency, malabsorption, etc. are all complications that can occur in Crohn's colitis. And they can also have extraintestinal manifestations, such as we saw, I showed you for ulcerative colitis as well. Now, the spectrum of IBD can be ulcerative colitis or Crohn's disease. Sometimes it is not possible even after the surgery, because these cases have already received some treatment, to make a definitive diagnosis of ulcerative Crohn's disease, because there are overlapping features. These 5 to 10% of cases wherein a definitive diagnosis of ulcerative colitis or Crohn's disease cannot be made, but it is an acute and chronic colitis, it is IBD, it is inflammatory bowel disease, those cases are called indeterminate colitis. So this is again from your textbook. Just a quick recap again. A patchy disease in Crohn's disease with transmural inflammation, continuous involvement in ulcerative colitis with only mucosal inflammation and pseudopolyps, and therefore, if you see certain indistinct features, then you can call it indeterminate colitis. This is all given in your textbooks, but I've just added these C's and U's to show you what is more common. Perianal fistulas, malabsorption, recurrence after surgery are more common in Crohn's disease, whereas malignant potential and toxic megacolon are more common in ulcerative colitis. Rectal involvement is more common in ulcerative colitis, strictures in Crohn's disease, lymphoid reaction, that Crony Rosary, fibrosis, serositis, granulomas, fistulas and sinuses, all more common in Crohn's disease. Deep knife-like ulcers in Crohn's disease, superficial ulcers in ulcerative colitis. Now, because of the presence of granulomas and because the fact that tuberculosis is so common in our country, it sometimes becomes important to be able to differentiate tuberculosis as well. So the granulomas that you see, you can sometimes see in ulcerative colitis when there is a crypt that has ruptured and that elicits a granulomatous reaction. But a granuloma that I showed you, which is not near, it is just near the crypt, it is not next to an inflamed ruptured crypt, that is commonly seen in Crohn's disease, but these are small granulomas. And a larger granuloma with caseous necrosis is typical of tuberculosis. And tuberculosis will have random distribution of the granulomas. They can be even in the serosa, whereas in Crohn's, they are more likely to be in the mucosa or the submucosa. Giant cells may be seen in both, but the typical Langhans giant cells and caseous necrosis are more common in tuberculosis rather than in Crohn's disease. And most importantly, the granulomas are quite large in tuberculosis, whereas they are smaller in Crohn's disease. And of course, if you find AFB, it is tuberculosis and not Crohn's disease. Now, colitis-associated neoplasia is the last part of this lecture. This sharply increases after 8 to 10 years, like I told you. And those with an earlier age of onset or pancolitis or an increased frequency of active exacerbations rather than the remission, those are the patients that are more at risk of developing colitis-associated neoplasia. Now, for that, the patient must be on endoscopic, colonoscopic follow-up very regularly. And what one can get is either a non-polypoid or a polypoid dysplasia, which can even be seen endoscopically by certain improved and these techniques can pick up the areas which may be plastic, and that is those areas then when they are sampled, biopsy is taken, and then the pathologist can confirm the diagnosis or say whether or not there is a neoplasia. So non-polypoid are usually small and they can be elevated or flat, but they are not polypoid. They don't have a stem. Or they can even be below the normal surface of the mucosa, that is depressed. And polypoid are usually slightly larger. They can either be sessile or pedunculated. So this is an area of a flat, endoscopically flat, not detectable unless you use a technique such as narrowband imaging, mucosa, which is dysplastic. Now, why is this dysplastic? You can see this region here. This is the way the normal colonic mucosa should appear, with lots of goblet cells and the nuclei present at the base of the cells. Whereas here, what you're seeing is nuclear crowding, stratification, loss of the goblet cell mucosa, and a very blue-looking appearance, right? This is dysplastic region. And this is also known as dysplasia-associated lesion or mass in IBD, because it could be just a lesion forming lesion. So if it is a mass forming lesion, then it's a dysplasia associated mass. If it does not form a mass, but is just picked up on random sampling during the follow-up endoscopies or by using expert techniques like narrowband imaging, and you see this dysplastic mucosa, then that is why these are also called dysplasia associated lesion or mass. Now this is an example of this flat lesion versus a polypoid lesion. So this is a polyp, a flat lesion over here that you can just pick up on endoscopy and biopsy, and this will show the dysplasia. And the type of dysplasia can be conventional, that is the way we see in an adenoma, which we will be discussing in the next lecture, or it can show various other forms of dysplasia, such as just increase in mucin or in the goblet cells or in the Paneth cells, but these are very specialized types of dysplasia that are very difficult to pick up unless you are aware of these forms of dysplasia, and I won't go into details of this. This is the type that I have shown you, and this is the type that we will be discussing along with adenocarcinoma of the colon in the next lecture on Thursday, I think. Now, sometimes you are not sure whether this is dysplasia or just inflammatory atypia. So when you are sure there is no dysplasia, you say it is negative for dysplasia. When you are sure that it is inflammatory atypia, you say negative for dysplasia with some inflammatory atypia. When you are sure it is dysplasia, you say that this is dysplasia, but it's not right now an invasive adenocarcinoma. But when you are not sure, and there are, many instances where there is some amount of atypia, some amount of inflammation, but it looks like the atypia is more than you could explain with the amount of inflammation that is present. In such cases, it is better to say that there is indefinite for dysplasia. So when it is indefinite for dysplasia, at least the patient will remain on a closer follow-up and a repeat biopsy will be done, rather than just calling it negative for dysplasia. So this is something that must be factored into the report by the pathologist. This is again another example of dysplastic region over here. There is a lot of inflammation over here. Now here in this region, there is some amount of crowding of nuclei and overlapping and nuclear stratification, which are usually typical features of dysplasia. But sometimes you are not sure because of the fact that there is so much inflammation here. And if you are not sure of this, then it is better to call it indefinite for dysplasia rather than saying that it is negative for dysplasia. Usually the dysplasia starts at the surface. So if you see this sort of change at the surface and not in this region, like it is seen in this particular microphotograph, that the dysplastic change is at the surface. It is usually dysplasia. It is not negative for dysplasia. And this is a typical example of dysplasia where the nuclei become elongated and crowded, and there is loss of the normal goblet cell mucosa, and this is a dysplastic change that is seen. Now, since my actual presentation is missing, there was a little take-home message in that also. So I will just wind up with the take-home message, in which it is important to recognize the entity of IBD with a multifactorial etiopathogenesis, and therefore the mainstay of therapy, because there is definitely a role of microbiota and our immunity. So the mainstay of therapy is immunomodulation with some control of the microbiota, either by antibiotics or probiotics or fecal microbial transplants, which help in maintaining the remission. The typical histology is often acute on chronic colitis. So it is important to be able to diagnose it and to be able to differentiate ulcerative colitis from Crohn's disease. And there are specific distinguishing features which I have already enumerated. And follow-up of these patients is very important because of various complications that can occur, such as toxic megacolon, strictures, and fissures. And of course, the most important complication that can occur is the presence of an adenocarcinoma, which is a complication that usually occurs after 8 to 10 years. So thank you very much for your patient listening. If there is any question, you can type it in the chat box and I'll be happy to answer. Yeah, some of you have rightly identified the adenocarcinoma that I showed you. And I think a lot of this will also be discussed in your tutorial today later in the afternoon. So I think I'll just end this webinar at this point. Thank you. Someone is asking about backwash ileitis. When the inflammation spills, when it's a pancolitis, in ulcerative colitis only, and the inflammation spills from at the ileocecal junction, goes back proximally into the ileum up to 2 to 5 centimeters length of the ileum adjacent to the ileocecal junction, that is called backwash ileitis. The reason why it's given importance is that sometimes Crohn's colitis can even have just an ileal involvement. So that has to be differentiated from backwash ileitis, which is a part of the pancolitis in ulcerative colitis and is not part of the ileitis in Crohn's colitis. So I will end the screen sharing now. Thank you all for your patient hearing.